Welcome to the Advancing the Kingdom podcast. We are streaming live on all social media platforms and podcast streaming channels. Get ready for a revelatory teaching from our apostle, Matthew Tillery.
Well, greetings. Thank you so much for tuning in to the Advancing the Kingdom podcast. I am your host tonight, Matt Tillery. I really appreciate you all. Thank you so much for tuning in tonight. What an awesome night we're going to have. Just really grateful tonight to have with us Dr. Denise Gooch. She's a board-certified radiation oncologist at Maryland Oncology and Hematology in Rockville, Maryland, and it's certainly an honor and a blessing to have her on this podcast tonight, and she's been with us a few times. Also, let me go ahead and get this out in the air. She's going to be joining us each month with a subject of her choice, and it certainly is going to be a blessing to you all as well as myself. So I'm excited to have with us tonight Dr. Denise Gooch. Thank you, Dr. Gooch, for coming on the podcast tonight.
Thank you so much for having me. I actually enjoy this a lot. This is something I look forward to, and I know this is going to be a wonderful hour that we're going to have, and hopefully we'll share some important information and really make an impact on everyone's life. So I'm definitely ready to get started. I'm very happy to be here.
Amen. Thank you so much. Once again, I really appreciate you. I know you're very busy in all the things that you are involved in. So just to take this time out in this space for us I really appreciate it. And certainly it's a tremendous blessing. Listen, those of you that's listening on Facebook, go ahead and hit the share button. Also, if you're on Facebook or YouTube, you can go ahead and if you have some questions tonight, you can type them in the comment section, and we will see can we get them answered for you on tonight. Once again, let's go ahead and get started. So let's go ahead and start with a question that I usually have a conversation with a lot of men about. And that question is, why is it, Dr. Gooch, so important that men get screened for prostate cancer?
It's so important because, unfortunately, prostate cancer is it's the number one cancer in the U.S., actually. Number one diagnosed cancer. Exactly. A lot of people don't realize that. The biggest problem is that it's also the number 2 cause of death, with Black men disproportionately affected by this. And this is why I'm so passionate about this, and why I like coming on this podcast or giving talks or attending programs to get this information out, because our Black men are disproportionately affected by prostate cancer. But as I said, it's important to remember it is the number 1 diagnosed cancer in men, and no man needs to die from prostate cancer. And unfortunately, some people who are probably listening to this either know someone who's been diagnosed. More than likely, I know someone who's been treated. Some of the people who are listening have probably been diagnosed and treated, but a man doesn't need to die from it, because the 5-year survival rate for a man who's diagnosed with prostate cancer early, before it is spread, is over 99%. As you said, I'm a radiation oncologist. I treat all kinds of cancer. Prostate cancer has the highest cure rate of any type of cancer that I treat. So that's why I'm so passionate about it. And anyone that knows me will tell you, Dr. Gooch will tell you, no man should die of prostate cancer. However, African-American men, 30% of deaths from prostate cancer in African-American men. So we're disproportionately, our men are disproportionately affected by this disease.
So do you think, in terms of getting screened, is that because of the fear of going to a doctor, or why do you think? Because if it's the most curable cancer and a lot of men are dying from it,
right?
Do you think it's a fear of just going to the doctor?
Yeah, I wish it were that simple. As a matter of fact, that's some of the research I was doing, basically getting ready for this discussion. And I think it's multifactorial. Sometimes it's the men, but I will be honest with you, sometimes it's the healthcare providers, that they're not really giving men the correct information. And I'm sure you've talked to other men who have told them that they may go to their healthcare providers And that's why it's technically a health disparity, because their healthcare providers may say, oh, you don't need to be screened for prostate cancer. That's not true. Black men are disproportionately affected because 1 out of 8 men in general is quote unquote diagnosed with prostate cancer, but 1 out of 6 African American men are diagnosed with prostate cancer. And as I said, 30% of deaths are from in African American men dying from prostate cancer. So there is a very strong health disparity with that. And it really, some of the research has shown that by healthcare providers discouraging men, and disproportionately, which is something I'm not real clear on, healthcare providers disproportionately discourage African American men, who have the highest incidence and the highest death rate, from getting screened. But yet, no offense to a Caucasian man may have an elevated PSA, they'll recommend they get biopsies. They don't recommend this active surveillance or watchful waiting. They will actually recommend they get treated. So that's, to me, unacceptable if we have a higher incidence, higher death rate, but yet you're told to do active surveillance. So
Well,
and
yeah,
that's very, yes.
yeah, that's very powerful, and it's so true, because I've had several men, even just really, it's really interesting, because over the last 60 days, I would say, I've had several men approach me about having prostate cancer.
Right.
And my question was that when the doctor told you that, what did they suggest? And this is no lie, 100% of the men that I talked to
Right.
said the doctor told them, don't do anything. Let's just,
Exactly.
don't do anything.
That's the most common thing that I hear. However, they've actually proven this for a white male with similar staging, okay, or similar diagnosis, similar PSA, similar Gleason's, they will recommend that they get treated. And one thing that really bothers me, and I always want to bring this up for men to know, that their primary care doctor, no offense to them, will say something like, oh, but the NCCN guidelines say that that for men who are considered at low risk, active surveillance is an option. But that's actually not what the NCCN guidelines says. That's a summary. But if you really look at the actual information that's given, they say that this is a heterogeneous group of men. And for certain men, number one, men who have a family history of prostate cancer, men who have, when they do the biopsy, they have more than 3 biopsy cores. And in particular, men who have I mentioned family history, so they may be BRCA, which is a genetic marker, positive. Those men should actually be treated for prostate cancer. Active surveillance is not a good option for them.
Wow.
So yeah, I hear that a lot. It frustrates me when I go to meetings and they'll say something like that, and I'll raise my hand and say, "Did you read the entire thing that the NCCN guidelines say?" And of course, everybody looks at me because they didn't. They only read the summary. So no, that's actually not what it says. It says it has a lot more information than just, oh yeah, you can just do active surveillance. And the other thing is that really bothers me when they say, oh, you can just do active surveillance. There's actually instructions what active surveillance means. It doesn't mean that I see you now and I see you 5 years from now.
Right.
Active surveillance by the American Cancer Society is actually that a man should undergo a PSA test every 3 to 6 months, not just once a year, once every 2 years. They should, well, they say a DRE, which everybody isn't that thrilled about, but that's okay. But they should also, yeah, I know.
You're not going to die from it, I promise you.
No, you're absolutely correct. They should also undergo another prostate biopsy. Why? Because African American men are more likely to have more rapidly growing disease. The disease that changes from maybe your PSA was 6 months ago, but then when they check it 6 months later, it's already gotten to 7. If they wait a year, it's already gone to 10 and 12. I see this every day in my clinic. I actually will follow the PSAs that have been tested and seeing it gone from 5 to 7 to 12. And then by the time they get to me, it's 24 and it's only like a year and a half. So that should be monitored, not just, oh yeah, come back and see me in another 2 years. No, PSA every 3 to 6 months. Add another prostate biopsy. That's actually what's recommended by the American Society of Clinical Oncology within 6 to 12 months of the previous positive biopsy. Why? Because when there was actually a study done in New York where they took hundreds of men, separated them out, okay, and did active surveillance for a few years. But then when the men finally went to surgery, African American men were disproportionately noted to have more high grade tumors. So basically, their tumors had actually become higher grade and more aggressive during that waiting period than the white males, and their survival was less. Their survival was 6% versus 92% for white males, who initially they were all at the same quote unquote stage and grade.
Wow. Yeah, like I said, I talked to several men and even have a relative now
Right.
that he went and his PSA was elevated high. I said, well, and the doctor said, well, we're just going to monitor it and so forth. I said,
No.
no. I said, you need to be aggressive with it. I'm telling you,
Yeah. You have to be, yes, you have to be aggressive, and you have to advocate for yourself. I heard when you and Professor Battle were talking about that. That is so important. Anyone who's on this call, please advocate for yourself. And if your primary care, tell them to read the entire part of the NCCN guideline. Tell them I said so. It's totally not just, oh well, just men who are low risk. No, because low risk is kind of a smorgasbord of a lot of different people, and certain people are at higher risk of low risk, and certain people are at lower risk. And as I said, when you have potential genetic propensity, if they have more than 3 biopsy cores, and if they have what they call high velocity, which is the kind of test that they run, those men should undergo treatment, because that's when you get those 99% 5-year survivals. All right.
Wow.
95% 10-year survival. So no man should die of prostate cancer.
Well, and when I got prostate cancer, I really became an advocate for prostate education because I learned so
Right.
much. And
Right.
even with my conversation that I had with you initially, before I even
Right.
did anything, it was the conversation that I had with you in 2022 that said, no, I need to be aggressive with it and I need to do something. I'm not just going to wait and see what happens.
No, we are not doing waiting. And like you said, I'm not, well, it's historically, even when I was in my training, they always said that it's more likely that a man, and I'm sure everyone has heard this, that a man will die with prostate cancer versus from prostate cancer. That's not true. It's the number 2 cause of death in this country. Okay. So they're definitely not just dying with prostate cancer. And unfortunately, African American men are more likely to be diagnosed at a younger age. That's something else that has sometimes doesn't come up, but it needs to come up. Men should not wait to the age, African American men should not wait to the age of 50. All right. They need to start their screenings at the age 45. And if they have a family history, first degree relative, brother, father, someone like that, they need to start getting screened at age 40. Okay. And
So, you guys heard that? Make sure
yes,
you say that one more time, Dr. Gooch.
I'll be happy to. African American men need to start getting screened at the age of 45.
Wow.
Okay. And if you have a family history, which means a brother, first degree relative, a brother, father, anyone like that with a history of being diagnosed with prostate cancer, you need to start screenings at age 40.
Wow.
Right.
Wow. And that's because of the way it affects African American men.
Disproportionately,
Right,
African
yeah,
American men are more likely to be diagnosed at a younger age. At
right,
one
right.
point, I think I had like 6 men being treated. I think only one was over 50. I had at least at least half of them were in their 40s, early 40s. I once actually treated twins.
Wow.
One was 42, and his brother had been diagnosed like a year before, and then 6 months later, he was diagnosed, and they were twins.
Wow.
So there definitely is, there's some research going on to see if there is something potentially genetic. Like I said, the BRCA gene, that stands for the breast cancer gene they talk about for women. They're actually seeing that in men who have the more high grade aggressive prostate cancers. All right.
Wow.
As a matter of fact, the NCCN guidelines, the National Comprehensive Cancer Network guidelines, recommend that men undergo genetic testing who are diagnosed with those high-grade prostate cancers. So that's actually in the guidelines. So you don't even have to convince your primary care, or they may say, well, I don't tell them it's in the guidelines. I actually have a presentation that I printed it up from the guidelines. They should actually undergo the genetic testing.
Wow. So I have a question here. There's an African American male that's 52 years old. His PSA went from 4.5 to 5.5 in 60 days.
See?
Do you? And the question is, I guess, do you recommend a biopsy, or what do you recommend in that case?
I definitely recommend a biopsy. Something else that I've given talks about, that we always make it sound like that 4 is that magic number, but it isn't necessarily, especially when it comes to African American men. At least 1/4 of men, in particular African American men, at a PSA level of 2.5 will actually have prostate cancer. And as I said, it just really bothers me that African American men are told to just watch for waiting, or we'll see what happens and things. But yet, if this were a white male, they'll actually get him biopsy. He will be recommended to get a biopsy.
Right.
So there's like a whatever bias, I don't want to call it some other things, but there's definitely a bias.
But it's a reality. Yeah, it's a reality. Yeah,
it's a healthcare. Yeah.
Yeah, but it's certainly a truth to that. And once again, they did not recommend that I do anything.
Exactly.
But I didn't settle for that. And it goes back to what you said earlier. We have to be our own advocate.
We have to be. As a matter of fact, there's actually an article that I actually found in WebMD that notes, we just talked about the racial disparities, and we already know that prostate cancer is more likely, Black men are twice as likely to die from prostate cancer than compared to other men. And actually, this article in WebMD stated this is the largest racial disparity in deaths from cancer than any other type of cancer. The prostate cancer, African American, it is the largest health disparity.
Wow. Why do you think that? I mean, what out of all the other types of cancers or cancer?
Well, as we said, unfortunately, African American men are more likely, 1.7 times more likely to be diagnosed. Okay. Right. Yeah. They're more likely to be diagnosed at a younger age. So unfortunately, by the time, in their 50s, they're more, especially if they have a family history or something like that, more likely to be diagnosed with the more aggressive form. Ooh.
Right.
We okay?
Right. Yeah.
So if by the time, unfortunately, they are diagnosed, they're more likely to have a more high-grade, more aggressive tumor, and that 99% cure rate that we are talking about may not actually occur because of the delay in diagnosis. That 99% cure rate is based on early diagnosis and early treatment, whether it's surgery or radiation, but definitely not watchful waiting.
Right. I asked the question. I asked the question. Right. What are we watching for? Just watching it continue to grow and kill me?
Exactly. Especially since African American men are more likely to die from it. I mean, that doesn't even make sense. I kind of parallel that to women getting screening mammograms. It's screening, right? Women get screening mammograms, dude. And I've brought this up in other talks. I said, can you imagine someone, if they found something on a woman's mammogram, they go, oh, well, why don't we wait about 6 months and see if that's changed at all? Do they do that? No, they don't.
Exactly. They don't.
They say, no, we're going to biopsy this. And do you know why that happens? I'm a cancer doctor, so I'm going to tell you. Because for a while, for years, they used to do that. It's like, well, let's see if it changes, it gets any bigger. And then by the time, I think you sense what I'm going to say, by the time they did biopsy it and they did diagnose it, more than likely it was no longer early stage, it was no longer curable, and places that, as a matter of fact, misdiagnosis on mammogram or radiology were the biggest lawsuits, the number one lawsuits in most hospitals and healthcare systems.
Wow.
So once they started getting those multi-million-dollar lawsuits for delay in diagnosis,
right,
stopped recommending that.
Right.
So,
yeah. So I guess here's another question. Is surgery always the best option for men with prostate cancer?
Well, that's a
What?
$1 million question. I'm a radiation doctor, but I'm honest with people, okay?
Right,
And I will
right,
give you my own honest, quote unquote, hopefully unbiased opinion.
right,
I think surgery is reasonable for quote unquote younger men, men with no quote unquote a lot of health issues, only because you have to recover from surgery. It is major surgery, all right?
right.
And so you have to realize that sometimes even some of my patients, I just saw a couple of people today and we were talking, they have this idea of one and done. Yeah, and then you talk to any man, and I'm sure you've had men on here who have had surgery. You have to keep that Foley catheter in for a couple of weeks. And I would say, no offense, but 80% of the men, because unfortunately, remember when I told you when they do surgery, sometimes they find the tumor is more aggressive than they thought.
Right,
At least
exactly.
30%, exactly. They still have to come and get the radiation anyway. So they've gotten both treatments, which I don't think is a good way to give treatment.
Right.
And hopefully you don't mind me saying this, but the
No,
risk
go
of
ahead.
erectile dysfunction is higher with surgery, even though the surgeons don't tell you that.
Right,
But at least a third to maybe up to 50% of men will have erectile dysfunction associated with surgery. They tell you they do this nerve sparing, but the problem is, and surgeons don't often know that until they get in there, that if this tumor is near those nerves, that they do have to, they're not trying to damage the nerves because they know this, but they do have to scrape it sometimes off the nerves, and men do have problems with erectile dysfunction. Like I said, it's low as 30%, but as high as 50% or even higher than that. So
right.
it has the highest risk of erectile dysfunction.
Wow. Yeah, I was pretty pleased with the proton radiation that I received. It was very minimal side
Yes.
effects, and
Yes.
it just kind of kept going.
And, and sometimes people ask me about the difference in proton, what that all means. Okay. And remember, you and I discussed this. So
Right,
what
right.
it is, it's a type of radiation, it's targeted radiation. And they use charged particles, protons, all right? But it's a huge machine. I use a linear accelerator, and I use something called photons, which is also kind of targeted too. But the proton is really exquisitely targeted, that it can actually go directly into the area and actually release its dose, and it doesn't have what we call exit dose. So all the beam, and I actually have pictures to show you, all the beam will incorporate the area of the prostate and spare the normal tissue around it. So it's actually a very eloquent way of giving treatment.
Wow, wow. But you know what? You kind of mentioned it about ED, erectile dysfunction. And I talked with a lot of men about that. I was scheduled to have a guy on last week, but he had a virus or something, and he was going to talk about this because that's very, we don't want to have these conversations, but
I know.
It's kind of touchy, right? We're sensitive, but we need to have these conversations.
Yes.
And one of the things that he was talking about the surgery and so forth, and then all the things that he experienced with that. In terms
and I'm sure he mentioned everything I just said, right?
and plus some more.
Well, exactly. I was trying to be nice about it. Exactly.
Yeah. But you're right. Everything you said, he talked about, because and not only that, but then the mental side of it too, right? You have to deal with that mental piece as well.
I'm glad you mentioned that. And this is something, as you said, and Professor Batter can tell you, that I've given talks on this. In fact, part of my talk, is it okay for me to go into detail?
Yes.
Okay.
Oh, yeah. Go ahead.
Part of my talk is the discussion of erectile dysfunction. As a matter of fact, I believe, and I've talked to some other doctors, even urologists, that we believe one of the main reasons men don't get screened for prostate cancer, or if they get screened, they don't want to get treated for it, is because of the risk of erectile dysfunction. And it's real. It's not.
Right.
It's not your imagination. It's real. And one thing I did find that I found extremely interesting, and I've incorporated in my own practice, is that for any man, and you may have heard me mention this before, that's undergoing treatment that I'm treating for prostate cancer, unless there's a contraindication, I start them on Cialis. Okay.
Right.
And there's actually been some research that has shown that these types of drugs, this class and classification of drugs, have been shown to lessen the amount of erectile dysfunction, and sometimes probably even better, to allow a man to maintain his ability to sustain an erection. In fact, for any man that I treat for anything, whether in their pelvis, whether it's for a prostate cancer, colon cancer, rectal cancer, anything, I start everyone on Cialis. And amazingly, it can be covered by insurance, not always.
Right.
But this is something else. I'm just letting you know that if it isn't, you can actually get it online. I'm sure you've heard about HIMS. And it's actually one patient, he was younger patient, with all the more reason why he needed it. I guess he was 45, but he went online and he could get it for like $5 a pill. So he decided to opt for that because the insurance company refused to do it. But yeah, I do that for all, unless it's a contraindication. And usually it's just a history of some cardiac events, because what it does, it's adult talking. It's about blood flow. It's about, air supply and blood flow. I think most people kind of understand that. Right. And so what it does is basically the medication relaxes the blood vessel, in a man's, male organ. So he's able to have an erection. And more importantly, it slows down the breakdown of the enzymes. So he's able to sustain an erection. All right. So that's why these medications work. And there's actually a study that I found that was done in New York, that they noticed that if they started a man on Viagra, I don't know why they just looked at Viagra, before his surgery, for men who were getting surgery, men had less erectile dysfunction after the surgery. So I'm a big advocate for that. Right. So I always tell men that if your doctor hasn't suggested it, ask about it. And almost always, what they'll do, they'll probably say, well, I don't care if you want it. They'll have not a dismissive, but they won't think it's that critical. But again, you need to advocate for yourself. Right. So you can tell them that you heard me say it. But yeah, I recommend any man who's going to get any treatment, either way, to get started on either Cialis or Viagra. The Viagra can be the 50 or 100 milligrams. The Cialis, the 5 or the 10. It just depends on, quote unquote, where a man is. You can start with the 5, and if you're not getting the response you want, you can go up to the 10. All right, but it's very well tolerated. They have very few side effects, and that's always been my recommendation.
Wow. So, and the bottom line is, men, you need to make sure that you're getting screened for prostate cancer. You need to make sure that you're your best advocate. You're taking care of yourself and doing the things that you need to do to live. Because at the end of the day, sex is not going to matter if you're dead. So
well, I know we talked about that before. Exactly.
Right. So you need to make sure that you're doing the things that you can do. Being that advocate for yourself, and not just you need to get a second opinion if they say that we don't want to do anything. We just want to do active surveillance, which was recommended to me, and I chose not to. I didn't like the term active surveillance. I just didn't like that terminology. Yeah. So
and it really bothers me, as you just said. Go ahead.
No, I was just saying I just didn't like the terminology at all. Active surveillance, just watching yourself let it grow in you. I didn't like that at all.
And I'm sure you've heard some men discuss their journey, that some men actually, once they took them to surgery, had more high-grade tumor. And that's something else I explain to people. When they actually do a biopsy of your prostate, it's kind of like an orange, and you're kind of sticking needles in an orange, all right? So let's say there's some bacteria somewhere in that orange, all right? Now, there is a chance you might hit it, but there is a chance you may not.
Right.
So that's another reason why I was talking about the active surveillance, quote unquote, means active if somebody really wants to pursue that, to get the repeat PSAs as well as a repeat biopsy in a year. Because if maybe there's some of the high-grade tumor, like I said, at least 40 to 50% of men who, once they go to surgery, have higher grade tumors than they were initially diagnosed with. It's quite high. So, that's another reason I have a problem with that active surveillance. So that's why it's not a coincidence that the PSA, which stands for prostatic specific antigen, Basically, it's only, it's a blood test, obviously, but
Right.
the actually antigen is a protein that's only made in the prostate. So
Wow.
that's why men are fortunate. I tell this to my breast cancer patients all the time. My breast cancer patients, we don't have a test that's specific, or that sensitive, that's only made in the breast and it's specific and gives us information about the breast. So men are fortunate that they actually have a test like this. So think about, this is a screening, a blood
Right.
test.
Right.
Women have to go through all kinds of things for screening and biopsies. Men have a blood test. I think that's quite amazing. And I really want every man to take advantage of that. I emphasize, no man should die from prostate cancer. No man.
Wow. Wow. No man should die from prostate cancer.
No man should. Martin Luther King Jr., you've heard me say this, and anyone who knows me knows I say this. I've given talks, and I say that at the end of my talk. Not that this is my end, but that's what I say. And I look at people. Martin Luther King Jr., and I look at him. He died from prostate cancer.
Right. Wow.
In case anyone didn't know that, that's what he died from.
Wow. Yeah. So we just have to take care of ourselves, man, and be more aggressive with it. Once again,
Right.
I think and I believe this podcast, one of the reasons I wanted to do this podcast is because I just really want to get that information and education out, because that we're not really, it's not going to be preached on the pulpit on Sundays. That's fine.
Right.
But we have these other resources that, just like you coming on tonight sharing, you sharing from a professional place as well as from an intimate place. So we're really blessed to have you on tonight to really just share. I mean, you're sharing from your own experiences and your knowledge. So we're really blessed to have you on to be able to share that tonight.
I'm honored to be here to share this information because, as I said, our African American men are disproportionately affected by it. You're 1.7 times more likely to be diagnosed with prostate cancer and twice as likely to die from prostate cancer, something that has a 99% cure rate. I tell people it's almost like a joke, but it isn't a joke. But I tell people, you don't have a 99% chance of making it to your car.
You don't. You don't.
What else? There is no other cancer that I treat that has that higher cure rate. I mean, as I said, this is what I do all day. I'll see women and I'll talk to them and I'll give them pretty good numbers. And,
Right.
They're feeling good and they're hopeful. But men, especially if it's early diagnosed and we know everything is still within the prostate gland, has not spread, they're sitting there just as nervous as the women, but their prognosis, they're going to be fine. And I reassure them, you're going to be fine. Right. You're going to be here. You're going to see your daughter graduate. You're going to see your grandbaby being born. You're going to be here, because that's what I want every man to hear this. You get yourself screened. You get yourself tested. You get yourself screened. You get yourself treated, whether it's surgery or radiation. I won't fight with anybody. My closest friends are urologists, okay?
Just do something, right?
Exactly. It's no fight for us. We're working together for a common cause.
Right.
But you get yourself treated, you will be here for your kids, your grandkids, and everyone is going to. As a matter of fact, I just saw someone today, and he's in his 60s, and he was just diagnosed with prostate cancer. He says, oh, yeah, my family doctor, she just decided to check a PSA. And I'm looking at him like, in your 60s? I mean, wow. That wouldn't have been too bad. But his father had prostate cancer.
Right, right.
And I'm just like, so I was trying to keep my face straight so I wouldn't, Right. And then I said, is there anyone else in your family? He said, oh, maybe my grandfather, too. I was like, oh, my goodness. It's like, okay. So I'm, trying to keep a straight face without saying what I wanted to say.
Look, can you talk a little, just a little about the Gleason score?
Sure. Yeah, I'm glad you asked. So basically for a biopsy, that's what the number they'll give you, almost like a cholesterol number. They'll give you a number. What the Gleason is, it's actually a scoring that they do that, the pathologist does based on how aggressive the tumor looks, all right? So I actually have a picture that I would show sometimes when I give talks that how the normal prostate cells look. They're kind of like little DNA and little, cells sitting there looking all nice and calm. But as they get more aggressive or their grade increases, quote unquote, you can see that the cells are starting to change. So what the pathologist does, which is why we usually have about 12 biopsies or 6 per side of the prostate, 6 per prostate, 2 on each lobe, because you have a right and left side of the prostate, just to let you know that they look and see how the cells look. Now, some of the cells will look, quote unquote, like the regular prostate. So those are what they call, they may be atypical or atypia, but nothing malignant. But then the more malignant appearing cells is kind of that they look angry. All right. So then they're graded based on how angry they look and what percentage of that biopsy core has those angry looking cells. So there's a couple of things you'll hear. Either it's a Gleason's 3+4 or 4+3. And that's something else is important. Now, I also train medical students. And I tell them 3+4 is not the same as 4+3. It sounds like it. They both equal 7. However, the first number is the number that's indicative of the most prevalent type of cell seen. So that's a 4. That's a more aggressive one versus the 3. So it's 4+3. So that's different than a 3+4, because that means that the 3 or the less aggressive cell was the more prominent cell. All right.
Right.
So that's what we look at when we look at, and then they're actually graded. So you have the Gleason's. So the grading is based on, we have grade groups 1, 2, and 3. That's something else. You'll probably see in a pathology report, they'll say grade group 1, 2, 3, 4, and 5. Right. So they are looking at the Gleason score. Okay. They're also looking at the PSA level. So to give you an example, grade group 1 is a Gleason's 3+3, a 6. Okay. In all of the biopsy cores. And that's something else. The final grade is based on the highest Gleason that's in there. So if there's nothing higher than a 6, it is a 3+3. And that's all biopsy cores. Nothing is higher than a 6. Now, if there's any biopsy core, you can have 8 biopsy cores that are 6, but if you just have one that's a 7, it's considered a 7, right? So it's based on the highest Gleason that is found in the biopsy cores. So a 3+4, right, with a PSA of 10 or less is a grade group 2, all right? Then if you get a 4+3, still a 7, and a PSA level of 10 or below, that's a grade group 3, all right? So we're, the grade groups are going up.
Right.
Now, remember that 4 I was just talking about, all right? So if you have a 4, all right, and in at least one biopsy core, all you need is one, you have 2 4s, so that's an 8, all right? So now you just bumped yourself up to a grade group 4, and the PSA level isn't as important because that's showing a more aggressive tumor.
Right.
Now, unfortunately, there is a 5. There is a Gleason's 5. That's considered, if you look at the biopsy core, there's no regular normal looking cells in it. It's all the aggressive malignant cells. So that's a Gleason 5. All you need is 1. All right. If you have a 5 in there, you just bumped yourself up to the grade group 5, unfortunately. Wow. So you can have a 5 and you can have a 4, but that 5, remember, that's the most dominant one. Right. Right. And the PSA doesn't really matter. You're still a grade group 5.
Gotcha. Good stuff. One more question. So what, I guess, can cycling cause prostate cancer?
Cycling does not cause prostate cancer, but I think I get what you're saying. What it can do, okay, is for a man to ride a bike, okay, there's something called your perineum, which is kind of the space between, okay, this is adult speaking, your scrotum or your balls and your rectum, okay, that space is called your perineum, all right? Right. And as most men know, that sometimes you got to adjust yourself to get comfortable right there, because if your equipment isn't set up well, you'll be uncomfortable, obviously, especially for long distances. Very. And I'm mentioning that you ride a bike, so you know exactly what I'm talking about. Now, the only reason we know that as doctors is because the PSA can be falsely elevated because there's a lot of nerve bundles in that perineum. So if a man's sitting on that perineum for a long period of time, his PSA can be falsely elevated.
Right.
So it's not that riding the bike causes prostate cancer, but it could cause the PSA, the blood test, to be falsely elevated because of that pressure, or basically irritation in the perineum.
Right.
Every urologist knows this, and if they find out that you ride the bike a lot, oftentimes what they'll do, a couple things. They'll usually start you on antibiotics, or they'll say, we'll repeat this, because and they may even say, don't ride your bike for about a week or two.
Right.
All right. And so not just riding your bike, even if a man has like an infection or a sexually transmitted disease, any of those things that can cause some irritation can cause your body to release some of this protein. It doesn't mean it's prostate cancer. That's like sexually transmitted disease doesn't cause prostate cancer. It's just an inflammatory response of your prostate because your prostate's inflamed. It's what they call prostatitis. So then a man is started on antibiotics, all right? And if his prostate level goes back down to whatever his baseline may have been, it was just probably from the irritation and or inflammation from whatever caused the irritation or inflammation.
Wow. Great stuff. Good information. Most of the road bikes, they have this cut out in the middle of the seat, which is designed specifically for that.
Yeah, that's something, is that perineal irritation.
Yeah.
Yes, sir.
So time is almost up. Is there anything else you want to share tonight, Dr. Gooch?
Well, it's interesting. There was something. I saw a very interesting article that I think was, of all the articles I've read, I think the most powerful article, at least in terms of an impact on me, that I read, and I'm glad you asked me this. There was actually an article published in the Journal of Clinical Oncology, all right, in 2023 by a group called Dr. Vickers and about 5 other physicians. And like I said, this is a very powerful article. I mean, to the point of I had to just stop what I was doing and look at it. And what the title of the article is that racism does not cause prostate cancer. It causes prostate cancer death.
Wow.
I know. I had to stop what I was doing.
That's powerful.
To me, it was a show-stopping, drop the mic moment.
Yeah, that's powerful. Wow.
Yes.
That's very powerful.
And I read the whole article just because I had to just stop what I was doing. Just like, oh my gosh, everything I've ever read, NCCN guidelines, American Cancer Society, everything, this impacted me more than anything else. Because what their conclusion was, that even though there's no evidence, obviously, that racism, nothing is causing prostate cancer. However, the effects of racism affect the chance that a man will die, or it influences the chance that a man will die as a result of being diagnosed with prostate cancer.
And what article was that?
This is actually, I can send this to you. This was an article published in the Journal of Clinical Oncology.
Yeah, send that to me when you get a chance.
I'll send it to you. Yes, I'll be happy to.
Wow, that's a powerful statement.
Yeah, that was, like I said, it stopped me dead in my tracks.
Yeah, that's powerful. Wow, that's one of those wow moments.
Yes, it was a mic dropping moment for me. Yeah, I've read thousands of articles, and I was just like, I literally stopped in my tracks.
Yeah, that's powerful. Wow. Well, listen, we're grateful tonight to have with us Dr. Denise Gooch. And look, she's going to be with us, and we're just blessed to have her come back each month. And she's going to be sharing whatever information that she wants to share. But we're just really blessed and very grateful to have her to come on and share. Just grateful for the friendship, the connection. Just really thank God for her, and also congratulations. I know I don't know whether it was last year or you were voted as one of the top doctors. So look, congratulations.
Yes. In the D&D, yes sir. Thank you.
Yeah.
Yes sir.
Keep doing the work. Keep doing the work. You're doing some awesome things, and thank you for the heart and the passion for people. I think that's very critical and very important. Even in what you're doing, you're not just doing it, but you also have a passion for people, and that says something in itself.
Thank you. Thank you. It's an honor and privilege to be here. I'm so looking forward to our monthly chit chat, sit down talks, because as you said, this is such an important topic. And you're right, I'm very passionate about this. And if I can just have one man, one family be spared the heartbreak of someone potentially not making it because of prostate cancer, it's all worth it. That's all I want.
Amen. Well, listen, this has been a great conversation tonight. Once again, we're very grateful and appreciative for Dr. Gooch coming on, just sharing. Just really thank her once again, and thank all of you for listening and watching. Listen, if you're over on social media, Facebook, go ahead and hit the share button. Let's get this information out. Just go ahead and hit the share button. I would greatly appreciate it. And if you're over on YouTube, go ahead and subscribe to the ML Tillery Outreach if you have not done so. Listen, I really appreciate you. Thank you so much. And just been a great conversation. I was really blessed by that last statement. That's still kind of stirring in me. So I'm waiting. I'm ready to read that article.
I'm going to send it to you. I'm going to send it to you.
Yeah, that's a very stirring thing right there. So I'm excited about that. Listen, once again, I am Matt Tillery tonight, Advancing the Kingdom podcast. My guest has been Dr. Denise Gooch. Once again, thank her for coming on. She will be back next month, every month, the fourth Monday at 7 p.m., and she will be sharing some great information. So once again, listen, I am Matt Tillery. Thank you so much for tuning in to the Advancing the Kingdom podcast. Listen, until next Monday night at 7, go and advance the kingdom.
We pray you have been empowered and blessed by this teaching. Join us next week for the Advancing the Kingdom podcast. If you would like to reach us, email us at mltillery@icloud.com.